Great. Thank you for the invitation. I am Dr. Priyanka Upadhyay. I'm a psychologist within the NYU Langone Medical Center system. And I work with the World Trade Center Health Program, which is a program for adults, survivors of the attacks of 9/11. So my bread and butter is pretty much working with folks who are traumatized and who have stayed traumatized for a long time due to an interplay of several medical and psychiatric diagnoses.
One moment, Priyanka. I'm just going to welcome everyone and orient them to the WebEx, and then we'll start with the slides, okay?
Okay.
So good morning, everyone. This is Priya Gopalan with the Community Technical Assistance Center, and I'd like to welcome you to today's webinar, which is going to be the topic of exploring the intersection of trauma and addiction with Dr. Priyanka, whom you just heard. This webinar will help participants to get more information about the subject and how to work with clients who are diagnosed or impacted by both. And before we begin, I just want to take a moment to orient everyone to the WebEx system so that you know how to participate. Please note that upon joining the webinar, you have been placed on mute to avoid any background noises that might distract others from listening to the presentation. If you come across any technical issues during today's event, please chat to the host who will be able to assist you. You have the opportunity also to submit questions for the Q&A portion that will be held at the last 10 minutes of this webinar by utilizing the chat box feature, which is located on the right-hand side of your screen. If it is not visible, please click the dialog bubble on the top right toolbar and it should appear. In order to ensure that we are able to answer as many questions as time permits, we are requesting that you send in your questions at any point during the webinar, including any case-related questions, and our presenter will address them during the Q&A portion at the very end. So we are very excited to have with us today Dr. Priyanka Upadhyay, who's a clinical psychologist, and I'm going to hand over the mic to her now to get us started. Thank you, Priyanka.
Okay, thank you, Priya. All right, let's get going. We have quite a bit to cover, and what I enjoy about these webinars and workshops is to actually make it as interactive as possible. So I look forward to your questions, which means that I'm going to try and skip over some things that are pretty self-explanatory and that maybe you can review on your own as well. So, as a professional, I come to the treatment from a trauma-informed perspective always. This means that in my clinical work, I'm conceptualizing a patient that I'm looking to treat in terms of how the culture in which I treat the patient is trauma-informed and how specific interventions can be tailored to treat a traumatized person who is usually dealing with comorbid disorders. So one of the comorbid set of disorders that we will be talking about today is substance use disorders, addiction. Now, we commonly know probably that they are present, more so than not, and are often related to each other. They are also recently growing into matters of national interest, health and well-being, especially with the opioid crisis. So when brought together, they often pose difficulties for programs, for providers, and clients alike, mostly due to the complexity of the clinical picture and a lack of integrated treatment and milieux. So let's start with trauma first. What is trauma? Dr. Gabor Mate, he's a professional, he's an addiction specialist. He speaks really eloquently about the relationship between trauma and substance use disorders in a way where he says that, the relationship between trauma and addiction is best understood in terms of pain and the attempts of a person to get away from pain, and there lie the roots of addiction. He asks, how can someone be in touch with their pain and heal at the same time? By being in the soothing presence of others. Because he says most addicts with depression, anxiety, or PTSD just want to get away from themselves, the pain that plagues them, just for a few hours. Okay, so let's try and understand this pain that comes from trauma. Trauma comes from the Greek word wound. These wounds can be experienced by a person They can be physical, they can be emotional, sexual, psychological, and/or social, or some combination. They can happen at any point in a person's life, but usually the earlier they happen and for longer, the more pain there is to get away from. Now, there are other important components too. So when is something traumatic? When our capacity to cope is overwhelmed. Christine Cloyter has a very wonderful definition that I go by, which is trauma is any circumstance that overwhelms a person's capacity to protect their psychic well-being or integrity, where the power of the events is greater than the resources available for them. SAMHSA echoes a similar definition where they talk about the 3 E's of trauma: the event, which can be a series or set of circumstances, the effects of the trauma, which are often harmful, sometimes life-threatening, and the person that is experiencing them. So the experience, the person, and the effect. So how does trauma actually impact a person? And this is important because the intersection of trauma and addiction happens in the realm of the world that the traumatized person comes from, the world where difficult, painful, tragic, abusive, invasive relationships impact the person, their brain, and their personhood. So if we go with the idea that trauma is a wound to oneself, one's personhood, it impacts how people perceive their worlds, their thoughts, their judgments, what feelings they allow themselves to feel, and what feelings they can't stop from having. Perhaps most importantly, trauma impacts people's sense of who they are. Trauma simultaneously causes acute physical symptoms, for example, like hyperarousal and emotional constriction. Trauma, importantly, shatters the trust that comes from feeling safe in predictable, fair, and loving relationships and environment. So trauma deeply impacts our ability to judge and learn, adapt, and create a life of meaning and purpose. So the strategies that people develop to contain and manage trauma reactions can ultimately develop into a disorder of control, being out of control and trying to be or reinstate control. So one of the most common manifestations, so the purpose of this talk today, while trauma can manifest in many conditions, not all of them requiring a DSM diagnosis, we will talk more about the most common and debilitating manifestations of trauma: PTSD, depression, and anxiety. Now, individuals respond to traumatic stressors, their responses vary. And many of us will experience a traumatic stressor during our lifetimes, but few of us will go on to develop a debilitating response such as abusing alcohol or drugs or PTSD. A powerful study to justify this fact was the ACEs study that people may be aware of, done by Kaiser Permanente, where they found that early adverse events such as abuse, neglect, or other traumas actually affected brain development and increased a person's vulnerability to encountering interpersonal violence as an adult and to developing chronic diseases, other physical illnesses, mental illnesses, substance-related disorders, and impairment in other areas of life. Why? Early life experiences shape the formation and the structure of the brain. So when researchers looked at women's brains, for example, who were sexually abused and had PTSD, their brains actually looked visibly different. So PTSD is a complex, multifaceted syndrome as a manifestation of trauma, and it's primarily marked by symptoms of horror or intense fear following a psychologically distressing event involving a real or perceived threat to physical and/or psychological integrity. So in a nutshell, the DSM-5 has 4 areas in which a person can have symptoms that need to at least last longer than a month and usually begin 3 months after. See, but this is not the only condition found in those with a substance abuse disorder. Depression, anxiety are very highly comorbid with substance abuse as well as PTSD. So let's quickly run through some of the numbers. What do we know about trauma? Findings from a large-scale epidemiological study by Kessler and his colleagues, they found that about 60 to 61% of men and about 50 to 51% of women are exposed to trauma. Within that, about 10% women and 5% men go on to develop a PTSD diagnosis. So if we are to look across gender, ages, the prevalence of PTSD, we are looking at, you can see in this slide, there is a clear gender bias here. More women are at risk of developing PTSD symptoms and meet criteria for this disorder. If any of you know Lisa Najewicz, the developer of Seeking Safety, which we'll briefly get into later, PTSD is 2 to 3 times more common in women than in men. What about addiction? I don't know if you guys can see some of the figures on this slide, but here's what I want to say about this slide. As you can see on the left-hand slide, this is from SAMHSA, in the past 1 year, there are some key findings that are probably not surprising to you. CNS depressants, central nervous system depressants such as alcohol, marijuana, are most highly preferred and used. We'll go into why a little bit later. Similarly with alcohol. So how does the DSM-5 think about addiction? We saw how it thinks about PTSD. Let's look at addiction. There are 2 usually groups of substance-related disorders that the DSM addresses. For our talk today, we're really just going to focus on substance use disorders, which share key features which include a maladaptive pattern of substance use leading to a failure to function in the world, which could be at work, school, home, and that result in legal, housing, financial, and relationship problems. These problems are clearly visible to the patient. They're significant others, and provider systems they interface with. So what happens is there is clearly a lack of functioning in the environment. There is a persistent sort of use, so a progression from substance misuse, abuse to dependence. So this causes other problems related to tolerance, avoidance of withdrawal, unsuccessful attempts to control use, and continued use despite the obvious physical, social, psychological, legal, and economic problems. Really briefly, substance-induced disorders, the DSM is referring to those that are a type of substance-related disorder that involves problems caused by the direct effects of a substance. Okay, so in the interest of time, I'm going to skip over a little bit and go over to the intersection. So SAMHSA created this slide, which I found very, very helpful because it begins to address what we know anecdotally to be sort of the relationship or the comorbidity between addiction and trauma. So take a minute to look at this. There is seemingly a low rate of overlap between these disorders. But what is known in a lot of the service utilization literature is that patients with PTSD and or comorbid conditions like addiction are high service utilizers. Okay, so what do we know about the comorbidity between trauma and addiction? As I mentioned, those with PTSD have at least one other disorder, 16% of them, and nearly 50% of them have at least 3 or more disorders. So because it is a complex, this is what makes PTSD, one of the most common manifestations of trauma, a complex disorder to treat. So there is a substantial set that struggles with both a psychiatric condition and addiction. When there is the presence of additional disorders, including PTSD, this appears to be more of the exception than the rule. The most common disorders, along with PTSD, are substance abuse disorders, anxiety, and depression, as I mentioned. Okay. So, what do these figures tell us about the relationship between trauma? These figures tell us this. We know anecdotally from our clinical work that the substance use disorders are extremely common in patients with post-traumatic stress disorder. The symptoms of these patients tend to be quite severe and tend to be more refractory to treatment than those of patients suffering from either disorder alone. We also may have a theory, each one of you may have a theory actually, about which came first and why. What the National Comorbidity Survey by Kessler and colleagues in 1995 found was that the relationship between trauma and addiction is complex due to many common brain pathways they both impact, the wide range of problems they both can cause, the diversity of symptoms that each of these conditions come with, and the lack of clarity on which came first and how. So let's dive in and talk a little bit about what we do know. We do know this: civilians and veterans with PTSD have elevated rates of substance use disorders. Secondly, among men with PTSD, alcohol use disorder is the most common co-occurring disorder, followed by depression, anxiety disorders, conduct disorder, and other forms of substance use disorder. Among women with PTSD, rates of comorbid depression and other anxiety disorders are highest, followed by alcohol use and dependence. Among veterans with PTSD, as many as 75% of combat vets met criteria for alcohol abuse or dependence. In the civilian populations, estimates of prevalence of lifetime addiction have ranged from 21 to about 43%. Let me see if that's mentioned. Sorry about that. Okay. So in the civilian populations, estimate of lifetime addiction have ranged from 21 to 43% with those who have PTSD, as compared to those who, as compared to those who have PTSD. Similarly, in the general population, rates of PTSD are sort of lower as compared to those on an inpatient substance abuse treatment, which is up to 42.5% and up to 62% of pregnant women in residential treatment centers. These are staggering numbers. We also know that both PTSD and a substance use disorder have other access to disorders: psychosocial, medical problems, inpatient admissions, and relapses, as compared to those whose substance use disorder isn't complicated by PTSD alone. So PTSD does complicate the picture in many ways. Now, one longitudinal study found that at 6 months post-treatment, those with PTSD had greater remission and less substance use than those with unremitted PTSD. So 2 pathways our understanding of how and why and where PTSD or trauma and addiction are related have been offered. One of them is the self-medication hypothesis, which is simply that the trauma happened and over time led to the development of a condition, most often PTSD, depression, anxiety, or the combination of any of these. So patients who use substances like, most commonly, alcohol, cannabis, opioids, and benzodiazepines, most commonly use these because they help with the acute PTSD symptoms. Similarly, the onset and severity of substance abuse parallels the onset and escalation of PTSD symptoms. And interestingly, which substances patients use, alcohol, marijuana, or stimulants, may stem from how actually they are bothered by their particular post-traumatic stress symptoms. So for instance, PTSD patients with alcohol disorder, use disorder, exhibit significantly more arousal symptoms than those with cocaine dependence and PTSD, for example. Now, this model has the most evidence in the literature. This can also explain some of what we might see in okay, we're still at this slide. So this is just sort of some of the research I'm sharing with you. So bear with me as I keep talking. The slides are going to change. Okay. The self-medication hypothesis can also explain if, let's say, someone is withdrawing from alcohol, they usually experience hyperarousal related to PTSD. So this is just often like, an alarm goes off and then they're re-experiencing their trauma. As the post-traumatic stress symptoms worsen, people are at greater risk for relapsing in order to self-medicate. So withdrawal in and of itself might be quite re-traumatizing. So that's where the stress of withdrawal and potentially additional trauma create a vulnerability towards maladaptive coping. So the self-medication hypothesis is also consistent with evidence that came from the ACEs study, which suggested childhood exposure really disrupts emotion regulation sort of processes. Now, at the World Trade Center Health Clinic, we often see a condition where a substance is used to cope with a traumatic event, such as 9/11, the exposure to the events of 9/11 itself. The pattern seems to often play out more often when the trauma occurs in adulthood. So this is an example, another example of addiction creating a vulnerability for re-traumatization. Now, the relationship between trauma, particularly PTSD and addiction, is also complicated because similar brain regions are implicated in both trauma and addiction. The relationships between the various systems that are involved, like the HPA axis, the noradrenergic systems, the dopaminergic and serotonergic systems, is beyond the scope of this talk today. What I will focus on today is sort of some of these interactions. Another pathway is that substance abuse disorders precede PTSD. So in order to sustain their habit, these patients put themselves in highly dangerous and potentially stressful situations, as a result of which they might experience high levels of physical and psychological trauma. Now, given that chronic substance use can lead to high levels of arousal and anxiety, as well as being sensitive to sensory changes to stress, substance abuse may result in a higher level, another example, result in a higher level of vulnerability to development of PTSD after traumatic exposure. So for example, cocaine addicts, while procuring cocaine, often expose themselves to highly stressful, potentially dangerous, life-threatening situations. So when they medicate or experience trauma in the context of substance abuse, these patients are at high risk towards not just maladaptive coping, but also development of PTSD. Okay, so given what we know, what is the work of trauma treatment, or what is the work of trauma-informed treatment for those dealing with PTSD, depression, anxiety, and addiction? If we look at the work primarily involves being able to regulate oneself emotionally, physically, and psychologically so that the traumatic stressor doesn't own you and the pain that results from the trauma isn't controlled temporarily through a substance. So the work of trauma-informed treatment for someone with any of these conditions and or an access to disorder with addiction is to feel less pain without feeling a compulsive need to escape it. But as you know, we humans are wired to heal and recover in the presence of loving and nurturing relationships. Emotionally healthy and growth-promoting relationships are truly at the bedrock of trauma treatment. So for most people, this can look like feeling free to know what you know, feeling free to feel what you feel, without feeling like those feelings are like a tidal wave. What does that involve? Being able to calm yourself, being able to calm your body, being able to maintain calmness even when you are triggered. And then within the calmness, when you're triggered or when you're not, finding a way to be fully present and engaged with yourself, people around you, and creating relationships that are based in authentic connection with other people, where you can be yourself and be accepted for who you are rather than be somebody else or put on a mask or put on a front. So this creates an opportunity to move beyond survival, which is where most folks with a trauma history live, to a place where they can thrive, where they have good relationships, they're taking care of themselves, they're taking care of their environments, choosing situations, people, places, and things that are less harmful, better for themselves and their bodies. But see, here are some inherent paradoxes of coming to this integrated treatment, which is the need from a trauma-informed perspective. In order to, if we look at healing from addiction and trauma, the work becomes one to regulate oneself. But in order to do that, we have to face what we cannot face. So it requires one to feel safe in the presence of something that is disturbing, painful, in all the channels, which is mind, body, and spirit. So the work then really requires some amount of being able to tolerate distress. Tolerating distress is one of the hardest things that a person with trauma can do. And so there is a lot of skill acquisition that is required. The harm reduction point of view in this sort of set of paradoxes is critical. How does one achieve better self-care, better relationships, better thriving life, independent of maladaptive use of substances, if one experiences excruciating pain from traumatic stresses and all that the client knows is to escape from it? The harm reduction approach in many ways is one that helps a patient be sort of fair to themselves, see themselves where they are, apply a good dose of compassion, even if it means taking a harder path in working towards abstinence or engaging in safe coping skills. But in order to reduce harm to oneself, one's environment requires, again, getting in touch with the pain. So, because trauma disrupts our sense of trust in others, oneself, and relationships, interacting with others is pretty much a malfunctioning process in a patient with history of trauma and addiction. These key paradoxes, the need to revisit, the need to build reciprocal, healing, nurturing relationships, and feeling safe in the midst of being triggered, and not feeling completely safe enough, have major consequences for treatment. So, here are some of the challenges. To the extent that psychological trauma has historically been addressed in addiction treatment settings, it's sort of been relegated to, let's wait until later, wait until the sort of the addiction symptoms have stabilized. This approach has really been congruent with, a priority of treatment goals, beginning with let's prepare and mobilize an individual for treatment. Let's then build a foundation of abstinence and control problem behaviors and build strengths in sobriety. And finally, work on peripheral issues such as marriage and familial dynamics, psychological trauma, mental health. But see, the current state of treatment of addiction and trauma is moving towards more of incorporation of an understanding of the relationship between substance abuse disorders and trauma. It is grappling with how addictive behaviors impact the management of trauma, the triggers and its various manifestations, and how do treatment providers, milieus, and systems look at where abstinence and withdrawal, which often can be a ripe ground for reactivation of trauma, can be incorporated into treatment. So the challenges of treatment of trauma and addiction bring up some questions about change of approach, change of culture, change of systems, and change of programs that would need to consider this understanding of the relationship between addiction and trauma. Okay. So let's, given that it is 11:30, I want to briefly go over some of the most evidence-based treatments for PTSD. Again, we are I'm limiting my talk primarily to PTSD because it is one of the most complicated and more common manifestations of an Axis I disorder in folks with addiction. But see, also remember that PTSD is a complex diagnosis that has comorbid major depression, anxiety, in terms of sleep difficulties, attention and concentration, in terms of dissociation. So there are a lot of overlaps in PTSD from these other Axis 1 diagnoses. So prolonged exposure is both in vivo and imaginal exposure. It comes sort of from a trauma-focused psychotherapy, which is a talk therapy that sort of helps people manage the anxiety that results from trauma and has them practice exposing themselves to and confronting gradually situations that they have been avoiding, and share these experiences with the therapist. So they also talk about the details of the trauma in depth, also done sort of just imagining what it would be like. So I can give you one example in our client population. We have a lot of people avoiding the World Trade Center area. So an imaginal exposure would be imagining yourself there and being able to manage yourself without unduly resorting to any maladaptive coping with the triggering of the particular revisiting of that center. Now, PE usually takes about 8 to 15, they have usually 8 to 15, it's a short-term treatment, 8 to 15 weekly sessions. They're pretty long. And this is a trauma-focused treatment that has a lot of research backing to it, both in the civilian and the veteran population. The next one, very close, is the cognitive behavioral approach, which is more so actually cognitive processing therapy, which is another type of talk therapy that has been known to be highly effective in those experiencing trauma. It involves homework, it involves writing assessments, but it basically teaches the trauma survivor to reevaluate the thoughts that they have about what happened to them. The idea is, that when somebody changes the way they think about an event, they can change the way they feel about it. So this is, again, a short-term but weekly session-based treatment. The other one is EMDR, and we'll revisit EMDR because I saw a very interesting study that is one of, I think, the first random clinical trials of EMDR in the treatment of patients who have substance abuse and post-traumatic stress disorder. So this is a treatment that was developed by Francine Shapiro, and it's sort of a groundbreaking therapy that is CBT-based, but is administered sort of across various milieux across the United States and internationally. And so it's sort of going to help people who have experienced a trauma, who have a difficult time making sense of what happened to them, and then find it challenging to sort of let go of the memories associated with the trauma. So this leads to negative feelings and memories, that continue to recycle and replay in the brain as though they were in a loop. So in EMDR, which is usually individual-based, but there are some group modifications as well, you work with a certified therapist where you remember the trauma, and the client is focusing on an object several, let's say, inches from their face, let's say like a pen or a finger, while moving that object back and forth rapidly and repeatedly to engage both sides of the brain to process the trauma. So this bilateral engagement is said to create a memory shift that causes recollections of the trauma to be less painful. It's also claimed to reprogram the brain and retrain it to relate to drug and alcohol use in a different way. So EMDR usually involves 1 to 3 months of weekly sessions that last up to 90 minutes. And usually some of the patients that I have done EMDR, the beginning stages of EMDR with, definitely have felt a little more in control, less triggered, able to make sense of what happened, and therefore function differently vis-a-vis their particular trauma. The next one I want to go over is stress inoculation training. It's sort of just like a vaccination against a particular disease. Helps your body respond quickly, or at least that's the idea with the flu shot. In the same way, stress inoculation training prepares you to quickly defend against PTSD-related fear and anxiety when you're exposed to reminders or triggers. So when you expose yourself to milder forms of stress, your confidence is boosted so that you can respond quickly and effectively when the trauma triggers happen. And there's another one that I want to quickly go over. Actually, there are two. One is TREM, Trauma Recovery and Empowerment. And I like this one because it is a longer session. I think it's between 24 and 29 session group intervention for women, developed by Maxine Harris, who've experienced, childhood trauma, focusing really on skill development, understanding the effects of trauma, establishing safety, monitoring oneself, setting boundaries, and creating a sense of empowerment. So as you will see in later integrated treatments, this is sort of where the field is going to. And two others really quickly. Skills training in affective and interpersonal regulation is an evidence-based skills-focused treatment that was actually initially developed to just provide basic social and sort of emotion management skills for individuals with PTSD and childhood abuse. So the motivation was really, promoted by the observation that individuals with childhood trauma frequently experience so many disruptions in various areas of their life that it can actually be used preceding trauma-focused work as a multi-purpose sort of rapport building, alliance building intervention, even symptom reducing intervention that supports and facilitates the effectiveness of trauma-focused work. And the last one is one of my favorites, and I definitely use techniques of somatic experiencing, developed by Peter Levine. He saw in the animal world, whose lives are routinely threatened, they were able to recover quite readily by physically releasing the energy they accumulate during stressful events. Humans, on the other hand, often override these natural ways of regulating our nervous system, with often feelings of embarrassment and shame and pervasive thoughts and judgments and fears. But what somatic experiencing does is that it helps people tune into the now and into the stuckness that often people with addiction and or trauma feel, to process it, to sort of free themselves. So some of the integrated treatments that have evolved from this understanding of this complex relationship between addiction and trauma, there are three of them that are really worth mentioning. And one of my favorites is Seeking Safety by Lisa Najowitz. There's a manual that's available and training. And this is an evidence-based treatment that was specifically designed to treat co-occurring diagnosis of PTSD and substance abuse. So it focuses on both diagnoses. Each condition is seen as interacting and adversely affecting each other. And there are several skills that are taught in the realm of safe coping, managing urges, riding the urges, and creating rituals that help manage addiction symptoms as well as PTSD symptoms. The next one, the Addictions and Trauma Recovery Integration Model, is really a mind-body-spirit-based model. It integrates CBT, relational treatment, while it emphasizes mental, physical, and spiritual health. And the last one that I want to quickly mention is Target, Trauma Affect Regulation, and sort of a guide for education and therapy. So this is more of a psychosocial intervention across adults, adolescents, adults, and families. And, it sort of provides that the psychoeducation component is very large in this, and it can be delivered in a group, individual, family, I think even in a home milieu. And I think these manuals are available as well. I'll be happy to share the link if needed. So what did all of these treatments find? Here are some of the kernels of truth that came out. They found clinically significant results through integrative treatment. Firstly, models like Seeking Safety found positive outcomes in significant reductions of PTSD symptoms, significant increase in abstinence from substances, and significant decrease in depression levels as compared to pre-treatment symptom levels. With a reduction in severity of PTSD symptoms, as well as adherence to abstinence in some populations, some of the lessons that we are learning is that treating trauma symptoms in a way that are alongside with addiction treatment yield clinically significant outcomes that not only impact symptom severity, but impact overall functioning, reduce crisis-based service use, and improve adaptive coping. They did a study in the VA population where those diagnosed with PTSD and an addiction were at greater risk of missing appointments. But with integrated PTSD and substance abuse treatment, they found there was a reduction in missed appointments and increased adherence to abstinence. Now, there is a study that is being done by Schaefer et al. That's actually available if you go onto Google Scholar. It is one of the first randomized controlled trials of EMDR with PTSD and addiction. And they are trying to look into if trauma-focused PTSD treatment in those with a substance abuse disorder will effectively reduce addiction-based symptoms like cravings and increase abstinence, as well as reduce PTSD symptoms. So there is a case that is building and that has been built over the last, one and a half decades, where integrative treatment is really becoming the way to go. So here are some of the guiding principles. Safety comes first. Creating and offering a safe and consistent environment for clients is the key to them being able to trust any milieu they are part of. Because trauma disrupts a sense of safety and trust, creating safety in sessions, which is setting and maintaining professional boundaries, giving ownership of the story of trauma and addiction to the patient, what that does is it allows them to feel free to share as much or as little. Some traditional addiction treatment approaches that, also sort of emphasize more of a confrontative approach can sometimes be disempowering or re-traumatizing, which will again disrupt a sense of safety. So before any clinician can engage in trauma-focused treatment and that of addiction, a set of robust coping skills needs to be in place. But the presence of a substance use disorder, whether abuse or dependence, but more so dependence, complicates this point. Why? Because of the need to maladaptively continue to use the substance to deal with trauma-based symptoms, if the self-medication hypothesis is one that you are going with. So this is where harm reduction models like relapse prevention therapy, motivational interviewing are immensely valuable in creating therapeutic alliance, dealing with ambivalence, and creating a buy-in to reduce distress and increase control. We'll talk a little bit about MI, motivational interviewing, but that really helps with behavior change by identifying desire to change, deemed as problematic by the patient, and do in a way that creates more of a collaborative working relationship. So change can seem more of a palatable possibility from this perspective. Another key guiding principle that arose is that education is key. People need to learn the language of emotions, learning to label them, understanding them, expressing them, receiving, and managing them. Because trauma disrupts and dysregulates brain systems that control these functions, the role of creating emotional expertise is a critical guiding principle of integrated substance abuse and PTSD treatment. So, CBT-based, DBT-based interventions, along with models like Seeking Safety and TREM, help a trauma survivor manage the toll of emotions without the maladaptive reliance or dependence on a substance. Of course, this is a process, but this is the eventual goal. So, another guiding principle is healing happens in a relationship, in trustworthy, safe, well-intentioned, and with consistent people and figures. So the role of creating a social support system or social capital that gets built, let's say, by being in group treatment, peer support, vocational, or having peers facilitated activities is a key component of these integrated models. And then another critical sort of element, guiding principle, is the need for ancillary services, where quality of life kinds of issues are dealt with through lifestyle changes. And lastly, while any mental illness carries the stigma that make people usually keep their pain as invisible as possible, relapses or slips in addiction often carry a great deal of shame. So Marlatt and Gordon, the developers of relapse prevention therapy, what they did is they incorporated relapse, which is a return to the substance of choice after a period of abstinence, as a normal part of recovery from alcohol or drug addiction. This made slips on the road to recovery a normal occurrence and further helped destigmatize relapse. So, if we are to look at some lessons, I've thought of them in two ways. One for the provider and two for the system. And I'm going to go with the provider first. So based on the relationship about trauma and addiction and these guiding principles that I just went over with you, certain core components have arisen, and there are many of them. This in and of itself is sort of one other talk, but I'm going to hit a few highlights. It's not a surprise to you by now that trauma and addiction affect the entire person, their view of themselves, their relationships, their overall functioning. So with such far-reaching consequences, it takes a village. And it takes a village of people, trained people, and it takes a village of interventions. So the core components involve a few ways to think about these core components. One is trauma-specific clinical work. That continues to remain the bedrock of integrated treatments, as these interventions are designed to ameliorate trauma symptoms, reduce not only PTSD, but probably depression, and positively impact adherence to treatment, abstinence, and reduce the likelihood of relapse. And the second category is ancillary but critical services that are required for the patient to maintain their focus on recovery is psychosocial supports, resource linkages to various legal, housing, vocational resources, and advocacy for their patient if there is a history of being involved in various legal issues or systems. So, lessons for the system. This is more of a top-down approach. According to the National Trauma Consortium for the Center of Substance Abuse Treatment, trauma-informed services that provide trauma-informed care take into account its impact, the interpersonal dynamics, and paths to recovery. So this is incorporated through all levels of service delivery. So if there is anyone here who is a manager or a systems person, in comparison to trauma-specific services that directly address the toll of trauma and addiction, these sort of ideas really target creating a milieu that facilitate trauma recovery and healing. So what could sort of be involved? It involves the system seeing trauma as a defining and organizing experience for the person. The system creates open and collaborative relationships with clients and providers, prioritizing still safety, healthy boundaries, client choice, and control. The systems would also integrate an understanding of trauma and substance use disorders through programs. So, for example, staff being cross-trained who recognize the interactions. They address trauma and addiction simultaneously and recognize the role of ancillary services are necessary components of holistic treatment. So as a system, some of the measures that a clinic or a setting would want to think about is making assessing for symptoms of trauma part of actually the interviewing or the hiring process. One model that I was exposed to was called Risking Connection, which provides cross-training to all staff. It's a common one that I was exposed to when I was in internship several years ago. Also including trauma in the assessment of patients at intake and through treatment. Importantly, focusing on the self-care of staff, which often, I can dare to say mental health professionals are not often good at. We have to work at it. But for example, using mindfulness and other relaxation strategies are very highly likely to reduce something that happens with many of us, which is vicarious traumatization and staff burnout. So a trauma-informed care system would take into considerations both the care of the staff and the patients, acknowledging the complex relationship of trauma and how it impacts the person. So one slide that I found really that put it together nicely is this particular one, because it sort of creates a model for us to look at how we can relate to trauma as a system and how we can relate to trauma as providers. So with that, I'd like to wrap up my presentation for today, and I'd love to hear your thoughts and comments and questions. Thank you.
Thank you, Priyanka. We are now going to end the session very soon with some of the answers to the questions submitted. As a reminder, you can still submit questions through the chat box, but I'm going to quickly go through a couple if we have a few moments, Priyanka. If
Sure.
you can talk, could you talk through or give us a quick summary of a case that you've had which was significant or where you did have to use any of these treatments that you spoke about?
Sure. So this is the case of an adult male, Caucasian male in his 50s. A survivor of 9/11, was actually a volunteer in the downtown area, saw a lot that day, saw people jumping from the towers, had a ton of exposure that were rich with risk factors for him developing PTSD just by in and of itself. So this man also, when he came in for an intake with me, had a history of alcohol abuse that he had, some control over in the years prior, but came from a very difficult childhood, had an alcoholic father, had a very chaotic growing up, was also a poor, came from a poor white family. So a lot of socioeconomic, psychological, emotional disadvantages was sort of part and parcel of this man's history. He began using alcohol in his teenage years and continued to use it, but described really himself as a functional alcoholic. He was able to function, he took care of his family, eventually got divorced, but, he was still functioning in his eyes. Come 9/11, 2001, there was a sharp decline in functioning. This sort of marked the idea that someone who comes to the table with a lot of vulnerabilities already is going to be at a higher risk of developing PTSD, depression, and anxiety, and he did. When I saw him 10 years after, at the 12th anniversary of 9/11, he was completely dependent on alcohol, came into the intake intoxicated, but was absolutely haunted at the same time by the flashbacks that he had of seeing the jumpers on 9/11, 12 years after. So the goal with this man was nothing but to completely allow him to tell his story. He came in, and one of the first things he said is, "Doc, you are the only person who wants to listen to my story. Everybody else tells me the message that I get is it's 12 years after, suck it up and move on." An invalidating environment is as traumatizing as the trauma in and of itself. So the first job with this client was to really help him speak and feel heard and feel seen in his pain, even though he was intoxicated. But see, safety also became a very critical piece of working with this gentleman. So after, about 30 minutes where he felt like I was listening, I was not jumping in to either send him to a detox or refer him to our ER, we were able to talk a little bit about how the alcohol was helping. And it was helping to numb him. It was helping him to sleep. It was helping him to just get through the day where he didn't have to feel haunted. The role of PTSD and addiction treatment was really exemplified in this half an hour with this man. What happened with him, fast forward, in about 2 months from that intake was he joined an integrative addiction and trauma treatment program because he needed to not feel all what he had avoided feeling by going into complete withdrawal. so the integrated program that he went into used a harm reduction approach where he and I began working on cutting down one drink a day. And that was coupled with a lot of safe coping skills, a lot I used from Seeking Safety actually, and grounding exercises. So this was sort of a case, that I can think of that comes to mind with alcohol dependence, PTSD, and major depression.
Okay, I think we have time for one more question. We do have a few more, and we'll try to maybe get to it after the webinar ends and have some responses from Dr. Upadhyay. But for now, do you have any recommendations for helping patients recognize the effects that their substance abuse has on making them more prone to re-traumatization of the trauma? Like, are there any tips or recommendations that you use?
One of the biggest things that I find really helpful is to find a source of leverage. What does that mean? Find an area in your client's life where they are absolutely unhappy and they want to change that unhappy. If you start there, again, this is overgeneralizing because it's so case by case, but if you find a patient who really wants to be able to sleep better, for example, a conversation designed around the pros and cons of not sleeping well, what's coming in the way of not sleeping well, and what are some of the things that they are willing to collaborate with you on, includes sort of a harm reduction approach. You're meeting the client where they are. You're helping them feel safe by not necessarily imposing, invading their sort of needs for treatment. And you're collaborating with them because now if they say, yes, I want to sleep better, how about we get you to maybe one of our psychiatrists, for example, and help you talk about sleep. But see, here are some of the other things that can tend to impact sleep. And that can begin a conversation about how the maladaptive use of a substance is causing them more harm than good. But here is the aspect of trauma-informed care too. There needs to be, a DBT principle called balancing the dialectic. On one hand, the alcohol, for example, is helping you sleep. On the other hand, you're still not sleeping well, so you're not functioning. Being able to help a client balance these two is a critical piece of motivational interviewing and creating that atmosphere where they're willing to change something.
Right. That's great. So thank you so much, Priyanka, and thank you everyone for attending today's webinar. The slides will be up on the CTAC website very soon, within the next 2 or 3 days. And we hope that you'll continue to join us for these webinars in the future. If you have any other questions, please contact us at ctac.info@nyu.edu. Once you leave today's webinar, you will receive a survey on the presentation, and we would really appreciate it if you could complete that and give us your feedback so that we continue to provide these webinars and this information in the format that you like. On behalf of CTAC and our presenter, thank you for joining us today, and have a great rest of your day. Thank you.
Thank you.